Greetings. So I'm going to be talking about the issue of gender binaries and specifically how some new thinking on sex, gender, transgender, and non-binary identities relates to this broader issue of women's health. So my goals are to sort of step back and have us rethink the concept of women's health. And to introduce some of the new thinking on the gender binary that changes the way we might view some of these issues. I'm going to introduce some information about the growing population of individuals who identify as transgender or non-binary. And I'm going to talk about why they pose some important questions that raise implications for the broader objective of gender-inclusive approaches to health. So many of you, or some of you, might remember that back in the 1970s was really when this increased energy and enthusiasm and activism around women's health really took place. And this was really exemplified, I think, in the book, Our Bodies, Ourselves, which was written and distributed by the Boston Women's Health Collective. And its goal was to really highlight that women were unique, that women had unique bodies and experiences, and those unique bodies and experiences had not been well represented in the conventional healthcare system, and that there needed to be specific attention to women with regard to healthcare provision, with regard to research. And that is true, and that movement has produced really powerful representation of women's needs. And it's part of the impetus for a conference like this one, right? However, there's a lot of assumptions that go into even having a conference that talks about women's health, right? What exactly makes a woman a woman? Are we talking about physical characteristics? Is it that we're talking about people who have breasts and ovaries and estrogen and a uterus and eggs and a vagina and follicles? Or are we talking about the broader experience of being a woman in a society which involves exposure to sexism, which involves coming into maturity and experiencing menstruation and pregnancy, your vulnerability to assault and victimization? That certainly is a worldwide risk that faces women. And what are the implications of our definition of woman for healthcare? So I'm going to pose a couple of examples that show how tricky these issues can be. So let's consider Jack, 30 years old, identifies and presents as male, but was assigned female at birth. Jack has had a mastectomy, takes testosterone to achieve a male gender presentation, but still has ovaries, a uterus, and a vagina. So if you want to do outreach about women's health and women's needs to get screening for breast and cervical cancer, those certainly apply to, someone like Jack, but will that message be effective if it is framed as a women's health issue? In this case, cervical cancer is not necessarily a women's health issue, right? It's an issue for people with cervixes. Another example, consider Jane, 60 years old, identifies and presents as female, was assigned male at birth, takes estrogen, has not had genital surgery. Jane's family has a history of prostate cancer, and so she should be screened for prostate cancer. But if Jane receives her care at a women's clinic that's not used to treating prostates, can they really effectively serve her? And then another example, consider Chris, 15 years old, identifies as non-binary or agender, which is a term that is sometimes used by individuals who don't identify as either female or male. Chris uses they, them pronouns, which is something that is often true of individuals who identify as non-binary. And Chris maybe dates both women and men, goes to a local health clinic for birth control, receptionist may have trouble categorizing their gender if they have an androgynous gender presentation. And imagine that this receptionist just asks straight out, oh, what are you, right? I need to know whether to send you to someone to give you birth control pills or someone to give you condoms, right? This can be an experience that's humiliating for anyone in the presence of an entire waiting room of individuals. Right? So the problem here is that our healthcare system and our entire society assumes and has long assumed that sex is a very tidy binary variable, right? We all acknowledge that gender is complex and culturally constructed, right? That gender roles are something that vary from society to society, but we tend to presume that there is something fundamental and essential and permanent and coherent about biological sex. And even when we use the term biological sex, we don't often acknowledge that we are lumping together in that category of biological sex a whole bunch of different things that aren't the same: genes and hormones and body style and body parts and brain anatomy, right? They're all biological, but they're all very, very different. And we tend to sort of lump them together in this category of biological sex. The problem is that sex is not completely binary. Even at a biological level, research is increasingly showing that it's more accurate to view sex and gender as mosaics, right? Where you can imagine different pieces, like different pieces of tile. They fit together to produce something that is understandable as an entire image, but the little pieces are not uniform, right? The extent of sexual dimorphism, in other words, the existence of two different forms, male and female, dimorphism that you find in one biological domain, like prenatal hormones, adult hormone levels, neurobiological anatomy, brain structure, brain function, the dimorphism that you find in one domain doesn't always correspond to the degree of dimorphism in others. Basically, this means that you can be highly female typical in one domain, right? For example, some structure in your hypothalamus that is typically different in males and females, but you can actually be more male typical in other domains of brain structure, brain function, hormone exposure, right? Now, you see this mosaicism most clearly in the cases of intersex individuals who are born with ambiguous genitalia as a result of differences in their sexual development. The most common form of intersex, and another term for intersex is differences of sex development, congenital adrenal hyperplasia, in which babies with an XY, karyotype, right? So they are genetically female, have a misfunction in the adrenal gland that causes them to be exposed to male typical forms of androgens in the womb. As a result, they are born with genitals that look more male typical, an enlarged clitoris, other forms of variation, right? So you have a mismatch between the genes, the hormone environment, and then the genitalia, right? So that's a perfect example of a mosaic, right? Where you have, differences, that these are individuals that are assigned female at birth and are raised as girls, but there are aspects of their development that are more male typical. And this mosaicism, although it's most extreme in those cases, really we're finding that it extends very broadly to individuals in the brain and in the body. And what this means is that when we use biological sex to categorize individuals, when we think of someone as male or female, we're really using those terms and those categories as proxy variables for a whole host of other things in the brain and the body that usually, but don't always, hang together in a coherent way, right? Usually, we can assume that someone categorized as female has a uterus and follicles and ovaries and female typical brain structure and female typical socialization. but that isn't always the case, right? So we're used to treating women as a group, and with regard to women's health, we might say, oh, women as a group have a different level of risk for breast cancer and depression, and we lump that together as a female typical risk. But using sex as a proxy in that way risks drawing our attention away from the actual and diverse biological and cultural causal mechanisms that might actually be involved in different mental and physical health conditions, right? Women may have a higher level of risk for both breast cancer and depression, but the mechanisms that confer that risk might be different, right? One might be more biological or might focus specifically on genetic risk with the BRCA gene and levels of estrogen exposure. The other, the depression risk, might have more to do with culture, right? So we're better off focusing on the actual mechanisms, hormone exposure, right, versus societal exposure, say, to sexism, than using sex as a proxy variable that kind of combines all those things. The additional problem with focusing so much on the gender binary is that it leaves a lot of people out, right? A growing number of individuals, and especially increasingly teenagers and young adults, more directly challenge the gender binary by identifying as transgender or non-binary, right? So transgender is usually used to refer to individuals who feel that their psychological sense of gender, their gender identity, doesn't match their birth assigned sex, right? The sex to which they were assigned at birth. And that's typically what transgender refers to, right? Other individuals, some of whom will identify as transgender and others may not, may feel that they are both male and female, neither male or female. These individuals often identify as gender fluid or agender or non-binary. Now, you may be assuming, well, this is a really tiny part of the population. And so do we really have to rehaul the way we think about gender in the healthcare system for such a small population? It's a larger population than many people realize. We now have good representative data on this. And in the United States, the overall prevalence of transgender adults is about 0.6%. So less than 1%. But that accounts for, that's equaling over 1 million individuals, about 1.5 million adults. The prevalence for youth is even higher. Representative surveys of youth have found that among individuals between 18 and 24, prevalence rates are 7%, sometimes 8%, depending on the state. Among those aged 55 or older, the prevalence is lower, about 0.5%. Among teens, representative surveys have found a prevalence rate of 1.8%, which is over twice the rate of young adults, 18 to 24. And if you ask teenagers specifically whether they identify as transgender or gender fluid, non-binary, the prevalence rate gets even higher, up to 3%. So this is a far larger population than most people think, especially among youth. Just to give folks a sort of primer with regard to terminology, because a lot of people are like, I don't even know what terms to use, and the terms keep changing. And that's true, terms keep changing. Generally, transgender is used to refer to the entire spectrum of individuals who experience some sort of difference between their internal psychological sense of gender and the sex to which they were assigned at birth. That term, assigned at birth, is what is typically used instead of the term biological sex, because as we now know, biological sex is not so unitary. It's kind of a complex construct. And so instead of saying biological sex, we say sex assigned at birth. And typically when doctors say it's a boy or it's a girl, they don't know anything about that child's prenatal hormone exposure or brain structure. They're looking at one thing, typically, the genitals. So that assignment is made on a relatively limited, piece of information. So instead of biological sex, it's now more common to talk about a birth assigned sex or sex assigned at birth. Trans is a shorthand for transgender that's often used as well when someone has a female or feminine gender identity, they will often identify as trans feminine. So when you hear something like trans female or trans male, that term is referring to their preferred gender identity, not the sex to which they were assigned at birth, right? So someone who transitioned from a male to a female identity would be called trans female or trans feminine, right? I've already covered why we talk about assigned sex rather than biological sex. Then there are intersex conditions, as I mentioned, like congenital adrenal hyperplasia. Those are sometimes called intersex, sometimes called differences of sex development, which is often abbreviated as DSD. Then there's a growing population of individuals who identify as non-binary, agender, sometimes they call it genderqueer, meaning that they don't identify with either male or female. Some of those individuals would count themselves among the larger trans population, others would not, so there's a lot of variability there. And then the terms cisgender and cis female and cis male are now used to refer to what used to be considered normal men and women, right? We want to question the whole notion of normality. But someone whose gender identity fits the sex to which they were assigned at birth would be a cisgender individual. So I am a cis female, right? I was assigned female at birth. I have a female gender identity. I'm a cis female individual. So with regard to healthcare, one thing that is sort of important to keep an eye on is the growth in efforts to provide gender affirmative care. In other words, healthcare that treats someone with respect to their preferred chosen gender identity, so that instead of having a transgender individual come in and saying, I don't care what you call yourself, what are you biologically? That would be obviously not a very hospitable healthcare, interaction for a transgender individual. So instead, there's a movement to really try to provide gender affirmative care that affirms individuals' psychological sense of gender, and that can provide hormones, interventions that can help them achieve their desired gender identity presentation, right? We used to talk about sex reassignment surgery, in which individuals underwent a whole host of medical procedures to switch from one gender to another. The problem there is that there are many trans individuals who don't necessarily want to go all the way from one end of the gender binary to the other. They may have a more nuanced sense of gender. They may not feel strongly about altering their genitals, but they may want to alter their appearance with hormones, right? So gender affirmative care usually involves an interaction with the individual to figure out what their preferred gender presentation is and what are the best means to achieve that gender presentation. So instead of sex reassignment as a unitary set of procedures, there's a broad range of interventions that a trans individual may want to pursue, right? Then there's treatment for intersex. This is an area that, over the years has been really controversial because there was a lot of surgery done on infants that parents didn't necessarily know a lot about. The infant is obviously not consenting. And there has been a movement to really be a little bit more patient and conservative about genital surgeries on infants to obviously promote effective, urinary function and things like that, but to be a little bit more conservative and patient about doing any surgery that is intended to simply change the appearance of genitals in order to satisfy sort of cultural norms about what females and males look like. So there's been, I think, a more greater sensitivity to non-binary notions of gender when it comes to treating those differences of sex development. Many, especially youth, who are questioning their gender identity and who see a therapist will often be diagnosed with gender dysphoria. This was a big change in the Diagnostic and Statistical Manual of Mental Disorders. It used to be that there was something called gender identity disorder of childhood, and that was replaced by a diagnosis of gender dysphoria. And one of the reasons for that change was to move away from pathologizing gender identity issues and to, have a way to describe this experience of a conflict between the sex to which you were assigned at birth and your psychological sense of gender, but to allow for the fact that some individuals are distressed by that and some individuals are not, right? That the mismatch itself need not be, disruptive or causing any sort of distress. For the individuals for whom it does cause distress, that's what can provoke a diagnosis of gender dysphoria. One of the sort of paradoxes here, as with all diagnoses, is that although being diagnosed with a mental health condition has the sort of smell of pathology, in our healthcare system, that's often what provides a rationale for insurance coverage for therapy and treatment. So we see that paradox, I think, in a lot of mental health conditions, and it's definitely one that's relevant to the area of healthcare for trans and non-binary individuals. A lot of controversy exists regarding the treatment of youth with transgender or non-binary gender identities. You'll often hear in the media this sort of sense that, oh my God, doctors are pushing young children to transition at very early ages. That is certainly not the case. Pediatricians who treat children with who are experiencing gender dysphoria tend to be extremely conservative with regard to treatment, because many of those children will experience changes in their sense of gender as they get older. It's only among children who have a pervasive and consistent and distressing experience of dysphoria that, doctors typically think about transition. And transition is usually the last resort and something that's not typically undertaken until older ages. A more common approach that's taken with such children is to administer hormones that will delay the experience of puberty, right? So if you've got a child who has persistently experienced gender dysphoria from a very early age, as they approach puberty, you can administer hormones to slow down that process, to give the child and the family more time to think and consider gender issues. That's a reversible treatment. So far, the studies have found it to be safe, but we don't have a lot of long-term follow-up studies, which is why it continues to be controversial. I should note that there are currently 6 states that are trying to ban all gender affirmative care for minors, even if their parents consent. So there is a lot of public health controversy regarding the treatment of these youths, and it gets wrapped up in a lot of political domains, and that's something to keep in mind. So I think the implications of all of this is that there are really 2 big problems when we apply a binary approach to healthcare. The first is obviously that we're failing to serve a large and growing population of transgender and non-binary individuals. But the second is more subtle, that relying on the gender binary sort of leads to habits of mind that force us to prioritize gender categories over other things that may be going on with a particular person's health. And that doesn't always lead to effective healthcare and effective policy. So what should we do? I think one thing that all healthcare providers can do is take a second look at their own forms and procedures and materials and practices to make sure that they're inclusive, to sort of imagine how a transgender or non-binary individual would experience them, and to really ask what aspect of sex or gender really matters to the healthcare that I'm providing. Is it calling my attention to something relevant? Is it distracting me from other causal mechanisms that I should focus on? Is there a way that I can be more specific in my language instead of referring to women, to just focus on what exactly am I looking at? Am I looking at, individuals with a cervix and a uterus, or, things like that. I think another example is family violence. Typically, primary care providers are accustomed to asking women if they've experienced violence in their home. Well, why do we, are we asking men that question, right? Are we making some inappropriate assumptions about who is even exposed to violence and who should be asked about that? So in conclusion, I'm not here to say that we shouldn't even talk about women's health anymore. There's a broader role, for this attempt to really focus on what sex and gender do in someone's life to change their health risks and their health experiences. But we need a more gender inclusive approach that really takes a critical look at the meaning and mechanisms of gender in the mind, in the body. And that will provide more affirmative care for trans and non-binary individuals, and it will also provide better health care for all individuals. Thank you very much, and I greatly look forward to your questions.